in Ireland from the 1970s and the 1960s, when the prevalence was even higher. So it's been coming down since the 1960s, it was coming down during the 1980s, and then when we finally have evidence about how to prevent neural tube defects, it actually pretty well stops coming down. There was a slight further decline, which of course is difficult to interpret. Was it due to supplementation, or was it due simply to a continuation of a pre-existing decline, which has not yet been well explained, really. And then in the rest of Europe, you see a continuous lower prevalence of neural tube defects and really no impact whatsoever of our new knowledge that it's possible to prevent neural tube defects. So why has primary prevention been so unsuccessful? Well, some suggestions can be made. A limited policy engagement in many countries, even those countries that developed policies. We've done a policy survey which is on the website, but even those countries that developed policy, perhaps a limited engagement in really making sure that that policy was going to work. Some perhaps complacency because of prenatal diagnosis and termination of pregnancy. Neural tube defects in many countries has become an almost invisible problem, and so it could be swept under the carpet and other things attended to. Another area is that health education is actually difficult. It's not a matter of having leaflets and posters that tell women to take folic acid. It's really a lot more difficult than that, and it needs more research. We need more knowledge that it's necessary to start folic acid before conception. And generally, surveys that have been done in the UK and elsewhere have shown that the level of knowledge among women that folic acid is good for you in pregnancy is quite high. But the level of knowledge that you need to start before you become pregnant is not at all high. And so women are basically starting too late. They're starting after the formation of the spinal cord, when they can no longer prevent the neural tube defect. Then many pregnancies are unplanned. According to the Department of Health website, about half of pregnancies are unplanned. Of course, it depends how you define unplanned, but in that case, it's not possible to start before conception. Healthy eating is not enough, and maybe the message that no amount of plates of spinach will ever give you enough folic acid to equate to folic acid supplementation isn't getting through. And then there are the traditionally hard to reach groups for health promotion messages, low socioeconomic status and educational status groups, and maybe not enough has been done to reach them. And the third area of explanation for why we've been so unsuccessful is the reluctance of UK and European governments to implement food fortification. It has been done in North America and in various countries across the world, but across Europe, food fortification, for example, by adding folic acid to flour, has not been approved, although it's been nearly approved in Ireland and the UK, but never actually implemented. So just as a little postscript to that story about neural tube defects, recently in Canada, an area which has introduced folic acid fortification of staple foods, they introduced that in 1998, and they looked at the prevalence of neural tube defects and found it to be decreasing. They also looked at the prevalence of severe congenital heart disease, for which there's less evidence that folic acid is preventive, but they found it also to be decreasing since 1998. And that seemed to be more than a coincidence, and so they hypothesized that perhaps, in fact, folic acid fortification was preventing severe congenital heart disease. Now, that was interesting to us in two ways. One is that we don't have folic acid fortification in Europe, so we wanted to see, is our prevalence also decreasing here? And the other is that in Canada, they did the study on live births, and we have access to all the data, including terminations of pregnancy, and we wanted to see whether it was actually a termination effect as opposed to a folic acid effect. So this is the European data now from 1990 to 2006. And the top line is all severe congenital heart defects, severe being more or less a group of congenital heart defects which usually needs surgery for the defect. And as you can see, if you include all the cases, live births, stillbirths, and terminations, in fact, the prevalence of severe congenital heart disease was rising during the 1990s. And then from about 2000, in our case in Europe, it started to decline as well. The green line is neural tube defects, now with 2 more years than you saw on the last slide. There's an indication maybe of a slight decline, but not nearly as much as congenital heart disease. So the question is, could this possibly be due to folic acid? We don't know that folic acid supplementation is increasing over time. We don't have fortification. And, if it is folic acid, then one hypothesis is that maybe the late uptake of folic acid during pregnancy or during early pregnancy, but later during early pregnancy, is more protective for congenital heart defects because the heart is developing slightly later than the spinal cord. So perhaps actually we're having more success with heart defects. But perhaps as well, it's not anything to do with folic acid. And we need to explain as well, of course, the rise during the 1990s as well as the decline in the 2000s. Nevertheless, whatever it's due to, it's sort of a good news story, I suppose, that congenital heart defects, having gone up, are now coming down. And another little postscript to the folic acid story is this analysis of congenital anomaly prevalence in relation to maternal age. And you see the prevalence per 1,000 births of congenital anomalies divided into non-chromosomal and chromosomal congenital anomalies. And it's very well known that the prevalence of chromosomal congenital anomalies like Down syndrome goes up enormously with maternal age, and you see that in the blue line. And in fact, you can see that of mothers of 40 years and over, their chance of having a chromosomal anomaly is about the same as their chance of having a non-chromosomal anomaly. But non-chromosomal anomalies are generally more frequent, except among the 40-plus mothers. But what's less well known is that older maternal age doesn't have a big effect on non-chromosomal anomalies, but young maternal age does. And there's a distinct increase in risk in young mothers. And if you look at this analysis also looked at the countries separately, that increase in risk is different in different countries, which suggests that it's not some biological effect of being a young mother and having a young body, but it's something to do with lifestyle and environment that differs in different countries and possibly differs over time as well. So really we need to look at what's happening among young mothers that's putting them at higher risk of congenital anomalies. And one thing, of course, is folic acid surveys have shown that they're less likely to take supplements and take them at the correct time. But that's not the only thing that's going on there. Okay, so my second example of surveillance in relation to primary prevention is around medication use in pregnancy. And what we've been developing is a child of Eurocat called Euromedicat to specialize in this area. And I think it's best expressed really the whole rationale for this. Alan Mitchell, who does surveillance in the United States, in Boston, of medication use in pregnancy in relation to congenital anomalies, wrote in the New England Journal of Medicine in 2003. Patients, prescribers, and policymakers often assume that the most serious short-term adverse effects of a drug are identified in pre-marketing studies. For drug-induced birth defects, however, the situation is reversed. The unfortunate reality is that we learn about virtually all teratogenic, in other words, malformation-causing effects, only after a drug has already received marketing approval, and of course only after it has been used by pregnant women. Teratogenic effects in humans cannot be reliably predicted from the class of a drug or from what is known about its pharmacology and toxicology. Studies in animals are seriously limited because of variations in species-specific effects, thalidomide being a very good example that didn't show birth defects in many experimental animals. Teratogens are not detected in human trials before marketing, since such studies are too small and exclude women who might become pregnant. So really we have no alternative in relation to drugs but to do post-marketing drug surveillance. So where Medicat has started over the last few years is with anti-epileptics. Anti-epileptics being a particularly important class of drug in that women with epilepsy need to take drugs of one form or another. They don't have the choice not to take them as a precaution. So we need to find out what are the risks of one drug versus another, and to be able to inform the decision about control of seizures for the clinician and for the woman. It's well known that anti-epileptic drugs are associated with about a 2 to 3-fold risk of congenital anomaly. And it's well known that valproic acid specifically is associated with a higher risk of spina bifida. But there are lots of questions. Are the newer anti-epileptic drugs that are now on the market safer than the older ones like valproic acid? And which specific anomalies, other than the well-known spina bifida, are associated with valproic acid, carbamazepine, and all the main anti-epileptic types? So the advantages of the EuroCat surveillance for this is that it's huge. Prevalence of epilepsy is about 3 to 5 per 1,000 pregnancies. Congenital anomalies only in 2% of births, and specific anomalies are often only in 1 per 1,000 births. So you really need an enormous population in order to have precise risk estimates. And also, as we have access to information about terminations of pregnancy, we can do a more unbiased evaluation of outcomes. So we started with a study of lamotrigine, a newer anti-epileptic. And this followed an alert from the US Federal Drugs Agency regarding a risk of orofacial clefts, specifically orofacial clefts. And this was based on an exposed pregnancy cohort, an anti-epileptic drug exposed cohort of 550 pregnancies in the US, the North American study, in which 5 orofacial cleft cases occurred when less than 1 would have been expected. And that was statistically significant. It was put out as a signal that there was a 10 to 14 times increased risk of orofacial cleft for a woman who took lamotrigine. So with our database, we set up a case malformed control study, a case malformed control study being one where we took the oral cleft cases as cases and all other types of malformations as controls, because the effect was meant to be specific to orofacial clefts. And 19 of the registries contributed to this study, and they contributed to the study with data from 1995 when lamotrigine was first licensed in Europe. And they covered altogether 3.8 million births, so it was really an enormous study during that period, and that's equivalent to a cohort study of about 12,000 or more pregnancies to epileptic women. So we had more than 5,000 orofacial clefts, 80,000 malformed controls. We weren't short of cases and controls in this study. And our results, and this is only one example, it's just illustrative, and it's illustrative really of the enormous size of study you need to look at drugs which are used infrequently in the population in relation to an infrequent outcome like, for example, orofacial clefts. But as it happens, our results for lamotrigine, you see in the first column there, those are the odds ratios. So we're looking for, if there's an excess risk, the odds ratios would be above 1 with a confidence interval that excludes 1. And in fact, we found, if anything, odds ratios below 1, but the confidence intervals including 1. So there was really no specific effect of lamotrigine at all. And certainly the upper end of the confidence interval was, for orofacial clefts in general, was somewhere between 2 and 3. So we could well exclude a 10 times increased risk. We really could not support those original results. But if we looked, on the other hand, at any anti-epileptic monotherapy, then we were finding the traditional pattern, in fact, that orofacial clefts are at increased risk in relation to anti-epileptic monotherapy. And we published that in Neurology because, of course, the whole point then of surveillance is to go back into the taking and evaluating of control measures. We want to get to the clinicians who are doing the prescribing, particularly the neurologists, and feed that information back into the cycle so they can evaluate this study against the original study and others to come. And we've gone on to look at valproic acid monotherapy and another one now submitted on carbamazepine monotherapy to try and increase the evidence base really